This is Susan Patterson. I'm just providing you with a supplement to your infection and inflammation PowerPoint presentation, part 2. There is one slide in there that goes silent as I talk about antibiotics, so I wanted to give you this opportunity to learn a little bit more about antibiotics with this additional lecture. Please keep in mind that the information I'm sharing is in your text, in your required reading. It's also in the handout that is available on Moodle. Under this week as well. And you might find it really helpful to go ahead and follow along with that handout. Before I get into the details of the particular handout and the list of antibiotics, I just wanted to carry on with the slide as it left off, and that is talking about the nursing care. It's important to assess your patients for signs of super or supra infection, and super or supra infection is when we are treating patient with an antibiotic for an infection, and in that process an opportunistic microorganism takes over and we see a secondary or opportunistic infection that also begins to take advantage of the patient. For instance, we might be treating someone with maybe vancomycin for a methicillin-resistant Staph aureus, and because it's a very strong antibiotic, it knocks out the normal flora that keeps our skin in check in terms of preventing yeast, and then the patient develops a opportunistic yeast infection. You might see things such as reddened kind of moist patches under the armpits and the skin folds. There might be signs of thrush or signs of yeast in the mouth and those kinds of things. So super or supra infection is simply when a patient is being treated with a fairly strong antibiotic, or sometimes even one of the more medium kind of antibiotics, and an opportunistic infection takes over and challenges the patient with a secondary infection as well. So that's super and supra infection. So you want to be on the lookout for that when your patient's on an antibiotic, just to make sure they don't have any signs of another opportunistic infection. You also want to check your culture and sensitivity, what was cultured in the particular culture or tissue that we might have sent to the lab, whether it be a blood culture, or urine culture, or throat culture. And then besides identifying the microorganism, what is that microorganism sensitive to in terms of the antibiotic? So it's important to check your culture and sensitivity. You also want to teach your patient to take their medications exactly as prescribed, which means they need to finish all the medications even when they might be feeling better. And we also want them to make sure that they are aware of any special ways that they have to care for those medications, such as some have to be refrigerated, some don't have to be refrigerated, and to make sure that they do that. Some medications should be taken on an empty stomach, others need to be taken with food, so they need to be familiar with any kinds of special instruction on that. In addition, we want to teach them any symptoms of allergy, if they develop any kind of skin dermatitis, or even any kind of respiratory manifestation as well. So we want to make sure that they're aware of allergy. And we always want to check to make sure they are not allergic to the drug. At least they do not know that they have an allergic to that particular drug. So at the end of the slide, I asked a question: what are the major side effects for antibiotics? And I just want to reinforce that the major side effects for antibiotics are nausea, vomiting, and diarrhea. Less frequently, we can see things such as allergic reactions, and those can be things such as dermatitis, rashes, those kinds of things. We can also see more significant allergic reactions, respiratory kinds of intolerances, bronchial constriction, and even anaphylaxis. And then one of the other potential side effects of stronger antibiotics can be organ damage, such as and organ toxicity, such as liver toxicity, a kidney toxicity, or ototoxicity, and those are antibiotic specific as well. All right, I want to now go into some of the information about the particular antibiotics. This is all on your handout, all in your text, all in your ATI information, all in your required reading. So the first group of antibiotics is the sulfonamides, and the sulfonamides were the very first antibiotics. They're still used today, commonly for urinary tract infections. Sometimes we'll see them for mild respiratory infections as well. And you might have heard of some of them. They include Bactrim and Septra. Now, you do need to be familiar with the categories such as sulfonamides, penicillins, cephalosporins, and how those drugs work, but you do not need to memorize the names of the drugs like Bactrim or Septra in this case. The reason for that is we really focus on classifications, but I give you the names of the drugs because for some students it helps them learn, or they might be familiar with some of these drugs, and that is helpful to them as well. So what you need to know is the first column that you see here, antibiotics, the categories, and the descriptions of the categories. The next category is the penicillins, and the penicillins are bactericidal, meaning that they kill bacteria. They do this by inhibiting bacterial cell wall synthesis, and they do this through something called the beta-lactam ring. They're often used for gram-positive bacteria, strep, staph, and enterococcus, and they're also, we can use some new penicillins now. What has happened over the years is bacteria have become resistant to many of the penicillins, and bacteria sometimes have developed an enzyme called beta-lactamase that attacks the beta-lactam ring, which is the effective part of the antibiotic. And when doing that, they render the antibiotic ineffective. And this is where some of those resistance that we're beginning to see more and more that certain bacteria are resistant to certain kinds of antibiotics, and many times it's because they have developed an enzyme that attacks the beta-lactam ring. So recently, probably in the last 20 years, we have developed different kinds of penicillins, ones that have a beta-lactamase inhibitor. So even though they are beta-lactamase antibiotics, we have also, beta-lactam antibiotics. Have now been developed to also include a beta-lactamase inhibitor, which inhibits the bacteria's enzyme beta-lactamase from rendering the antibiotic less powerful. And so some examples of penicillins, simple penicillins, are ampicillin, amoxicillin, and penicillin V or penicillin VK. And then some examples of antibiotics, penicillins, that have a beta-lactamase inhibitor are Unicin, Augmentin, and Zosyn. Your book gives some additional information about beta-lactamase inhibitors in antibiotics as well. Cephalosporins are the third category, and these are also bactericidal. They inhibit cell wall synthesis, and they do that again through that beta-lactam ring. They have a very broad spectrum of activity, and they are very similar to the penicillins. They're so similar that sometimes the patients who are allergic to penicillin may also develop a cross-sensitivity to cephalosporins. So you want to be very careful if you have a patient who is allergic to penicillin, we put them on a cephalosporin, that you teach that patient it's important to watch out for the same kinds of allergic response. Some patients never develop those kinds of allergic responses, some patients do. Some examples of cephalosporins are Ciclor, Ancef, Keflex, Keflen, Ancef, and Rocephin. And some of them can be given orally, others are IV or IM. Tetracyclines are the next category, and they are bacteriostatic. They also affect some protozoan. They inhibit protein synthesis, and they can cause tooth discoloration in kids when mom takes tetracycline during their pregnancy. So for that reason, they're contraindicated during pregnancy. They are the drug of choice for Rocky Mountain spotted fever, for Lyme disease, for chlamydia, and rickettsia as well. Aminoglycosides are also bactericidal, meaning they kill bacteria. They are given for systemic infections, usually pretty potent systemic infections. They have a very poor oral absorption, so they're usually given IV. Serum levels are monitored to prevent toxic levels. We do peak and trough levels on these antibiotics, but also we want to maintain the most therapeutic levels. That's also another reason why we can do peak and trough levels. The side effects include ototoxicity and nephrotoxicity. Some examples of aminoglycosides are tobramycin, amikacin, gentamicin, and neomycin. The next group is the quinolines, and the quinolines are potent broad-spectrum antibiotics, and they can be very effective against both some gram-negative and some gram-positive microorganisms. They work very well for obscure bacteria like anthrax, and if you were around during 9/11 and recall that that white powdery substance was being delivered to certain places in the U.S., the drug of choice that they used to treat anthrax for those folks that came in contact with it was something called Cipro. And we hadn't really heard much about Cipro prior to that, but it is a very good antibiotic because it has that wonderful broad spectrum, but it's also very, very effective as well. It can be given orally, and the oral route can work very, very well, as well as some IV antibiotics. And it can also be given IV as well. So Cipro is the oral form, and then ciprofloxacin is the IV form. And then another drug in this category is Levaquin or levofloxacin. The next group is the macrolides, and the macrolides are bacteriostatic, so they weaken bacteria. And in large concentrations, they can also be bactericidal as well. They target both gram-negative and gram-positive microorganisms, and they're similar to penicillin and can cause GI cramping and GI upset. They're often given for Lyme disease, for Legionnaire's disease, and chlamydia. You probably have heard of Z-Pak. Z-Pak is Zithromax, which is one of the macrolides, and then erythromycin is another one. Vancomycin is a category within itself, and these are antibiotics that are bactericidal, especially for resistant staph like MRSA. They require peak and trough levels to be done, and they can cause ototoxicity and nephrotoxicity. The oral absorption is poor, so many times for more significant systemic infections, we are giving these IV. However, they are given orally for C. diff because they're poorly absorbed by mouth and in the GI tract. They still seem to be at concentrated levels within the intestine, so they can be very effective in the treatment of C. diff in the oral form. And the only drug in this category are the vancomycins. The carbapenems are beta-lactam antibiotics with a broad spectrum of antibacterial activity. They are bactericidal and they inhibit cell wall synthesis. They are highly resistive to most beta-lactamases. They are the antibiotics of last resort for bacterial infections like E. coli, Klebsiella, pneumonia, and there is great concern now over carbapenem-resistant strains of bacteria, or CRE bacteria. The side effects for these drugs include seizures. Be very cautious in the use of these drugs with patients who are allergic to them, or allergic rather to other kinds of antibiotics as well. Patients who are allergic to penicillin can have cross sensitivity here, and these particular antibiotics need to be infused very slowly over about 60 minutes. So they're very similar to the penicillins and the cephalosporins. Again, these are the antibiotics of last resort, and we are beginning to see more carbapenem-resistant strains of bacteria, which is of concern to us. Some examples of these are imipenem, ertapenem, and cilastatin. All right, so that includes a mini lecture on antibiotics to replace that one slide that kind of went mute on you. Thanks for listening.